Hello and good evening to all. So today is webinar number 126 in our series of Sunday Critical Care webinars from our forum Young India Intensivist. And the topic today is actually something which deals with from what happens after the ICU to the patient. But what this is happening in the ICU itself. So what happens in the ICU, but something which the patient has after the ICU. So it's very important. Post-ICU care syndrome or post-intensive care syndrome or PICS as it's called. And the speaker today is Dr. Leelavati Thakur. She is an intensivist at the Mission Hospital, Durgapur, West Bengal. So I hope everybody will find this useful. And this is something we don't talk about very often. So over to you, ma'am.
Thank you, Dr. Tapesh, for your kind introduction. And good evening, everybody. So we start over here regarding a very, very important outcome, ICU outcome, that we generally do not give so much of care to it, but we should give care to it so that our outcome improves a lot. So this is post-intensive care syndrome or Pics. Pics, actually, this terminology has generally evolved over the time as our care of intensive care has evolved dramatically over last few years or last quarter century, you can tell. So here the technical innovation, the guidelines, improving guidelines, and the standard of care, and different equipments of care, those have evolved so much so that our outcome of the intensive care patients has actually improved a lot. And improved, yes, it has improved, but there is a query regarding the actual outcome of functionality of the patients. That is what I'm going to discuss about this in post-ICU care syndrome, today's lecture. So starting during our COVID pandemic, we had seen so much of stress in the patient's family, and definitely the caregivers. So we tried to reduce the stress between the patients and the families by setting them across the video calls, and tried to relieve their stress also by almost always staying nearby their bedside. So now, considering all those things, the long-term prognosis and quality of life, the Society of Critical Care Medicine has an initiative of named Thrive. And Thrive initiative is now spreading across the world and doing all major studies and looking after the outcomes and the problems which are now cropping out after the survivors go home. So this December 2018, the Thrive, Thrive proposal from SCCM, they had studied and they're now doing actually 3 or 4 major studies all over across the world. And this is one of the Pics study by ATS that was also funded by SCCM. Those have categorically shown that desired outcome is the survival, discharge home, stay home and improving, and return to the functional baseline. But many a times this does not occur. So the impediments which actually delays or deters the outcome is mostly, one of them is the bad or inadequate, I'll say, correction of the sepsis, like late antibiotics and source control, hospital-acquired infection, ventilator-associated pneumonia, lack of DVT prophylaxis, and not following the typical ARDS protocol, And then again, during the discharge of home, the patient is not mobilized adequately. Patient is having some delirium. Patient is not rehabilitated properly. There may be polypharmacy, so on and so forth. There are many things. Those are now cropping up during these studies. So the studies are actually being done on a regular basis. And now you see one study like this has already happened in 2016, which was published in 2016 Critical Care Medicine. Those had actually utilized the data from two RCTs like Erythroian and Prior shock. There are two big studies that had happened with the for the fluid protocols and all. So we all know that patients in ICUs from America, Europe, Africa, Asia, Australia, those were all taken into account who had severe sepsis were incorporated. And typically these patients were functional and living at home without help before the hospitalization with sepsis. Now, regarding the results, you see almost the Erythroian versus the Praves cohort, they showed almost the similar outcomes as you can see here. So these studies are now continued, and Society of Critical Care Medicine has taken a very big step in preventing PICS. What do we mean by PICS now? PICS is nothing but new or a worsening impairment in physical, that is ICUAW-acquired neuromuscular weakness, cognitive thinking and judgment, and mental health status. Three major part of this PICS. This arises after the critical care illness in ICU, during discharge, or at home also. It's persistent and persisting beyond discharge from the acute care setting. That is called PICS. Even the subsets are PICS family. The family next of kith and kin of the patients, they also undergo some kind of a cluster complications like anxiety, acute stress disorder, post-traumatic stress, depression, and complicated grief. These are also a part of PICS itself. And another subset is the pediatric subset that I'm not going to discuss in details, because PICS-P and PICS adult, those are almost similar. Regarding the pathophysiology, the molecular mechanisms are there. These are actually very many methods by which this occurs, this injury and cellular injury and the changes in the muscles, the nerves and all, to create this ICU-acquired weakness and the other components of PICS. During acute inflammatory response, you can see the damage or pathogen-associated molecular patterns, DAMs, PAMs. They induce initial systemic inflammatory response mediated by the release of pro-inflammatory cytokines like GM-CSF and other cytokines like IL-1, IL-6, IL-17. These already start the damages, and naturally the compensatory anti-inflammatory response syndrome by IL-10 and TGF-beta, those cytokine and cytokine antagonists, they also take into account of this and then come to help the more damage, create more damage. And mostly senescence-associated secretory phenotype, which I am going to tell in greater details, where you can see here, even this is just an example of this cell-mediated injury of chronic lung dysfunction. You see, whenever we see a patient of ARDS, you see there are initially the proliferative, then fibroproliferative. These fibrosis are initiated by all these cytokine mediators, the inflammatory mediators, epithelial mesenchymal transition, and changes in the cell population, local inflammation. These are all they produce some epithelial dysfunction and impairment of the cell renewal that cause the chronic lung dysfunction. Later on, in COVID fibrosis, we have seen a lot of patients, they have a permanent fibrotic damage in their lung that we see. Even for sepsis patients, normal sepsis patients, they also have a fibroatelectated lung changes that have already, that damages the lung, many are cases beyond repair. So during chronic inflammation, unbalance between the pro and anti-inflammatory mediators make homeostasis impossible to restore. So this is how mostly the molecular mechanism of cell injury, cell-mediated injury that take place. Next, coming to see the cognitive impairment, how the cognitive impairment happens. Like you see, with the inflammation, the stretch receptors, the organ feedback, and the dopamine release, those affect the neuronal apoptosis and cell activation amyloid deposition. Ultimately, this amyloid deposition actually initiates this cognitive impairment and the neuronal damage. Even with the systemic inflammation, the blood-brain barrier injury, all cytokines, cell translocation, they also help in the process. Now you see what systemic inflammation, which how it affects the muscles, like protein synthesis, the satellite cell activation, differentiation processes, myoblast proliferation, macrophages, angiomyogenesis, those are all affected. And ultimately, you see the proteolysis is also affected, loss of myosin, again, the muscle apoptosis, skeletal muscle waste, and calcium homeostasis, those are all affected during acute inflammatory disease like sepsis, and eventually mitochondrial dysfunction, and that will create again polyneuropathy. Two major things that we generally do not come across or did not give so much of importance till now, now they are playing a big role in creating this PICS, like senescence and integrated stress response. This senescence is the cell cycle arrest and shift to loss of several cell functions, but there is a process that resists the cell death. So the cells are like aged, they lose their cell functions, but they are not able to do their work, but they're not dying again. So like us only, we are now aging. So this is how the senescence acts, and emerging pathogenetic pathway in idiopathic lung fibrosis. That is how the idiopathic lung fibrosis occurs. And the integrated stress response is a conserved cell response to a different pathological condition that results in generalized protein synthesis and expression of a specific gene signature to maintain the cell homeostasis. This is again integrated stress response, is the opposite to the senescence. This response may be activated by 4 stress sensing kinases like PKR and PERK. PKR like endoplasmic reticulum kinase, leading to a decrease in the protein synthesis. Ultimately, the protein synthesis diminishes, and these pathways converge in reduced number of cell responses that produces apoptosis. So this is in short manifestation, acute manifestation, and a post-intensive care manifestation. Those are due to that apoptosis occurs, like delirium, acute lung injury, acute myopathy, organ failures, chronic organ dysfunction. These are the chronic ones, like neurophysiological impairment and chronic lung dysfunction, chronic organ dysfunction, and other ICUAW weaknesses. So what are the spectrum, which all we see during discussing the PICS or F? PICS encompasses physical and brain or cognitive symptoms and emotional symptoms. Physical means ICU-acquired muscle weakness, fatigue, decreased mobility, difficult sleep, insomnia. These are all we can come across. And brain, the cognitive symptoms are memory, those are decreased, thinking problems are clouded, difficult talking, then forgetfulness. Then the emotional symptoms are PTSD. PTSD is a very big term, very wide term, post-traumatic stress disorder, which most of the patients, they go through it. And we can very frequently see this during our the patients who are going to get discharged from ICU. Those patients declare, I mean, they describe like nightmares, unwanted memories, anxiety, depression, and some they're not motivated enough to perform whatever they're asked to do. Those are part of the post-traumatic stress disorder. And regarding Pics family, in caregivers may include the anxiety, depression, feeling overwhelmed, again PTSD, and grief response. They also have changes in sleep patterns. So these are the complete spectrum. Pics family, here you can see survivors, they have got mental, cognitive, and physical impairments. How to diagnose it differential? The differential diagnosis is a complete, Pics is a complex disease process that overlaps with many other symptoms like stroke symptoms, the electrolyte abnormality, the endocrine disbalance, nutritional deficiency. Those are all, I mean, come into the differential diagnosis whenever you diagnose a PICS. Cognitive decline, we have to rule out all those before defining a PICS in a patient. Cognitive decline, dementia overlap, and then Alzheimer. Those may be actually a precursor, pre-hospital scenario. They may be from the pre-hospital scenario in those patients. So we have to rule all those out. Memory deficits, maybe patients are having, and severe depression, that also are part of their psychological illness earlier. The mental health manifestation of Pics-F are similarly complex, and that may also exist with other psychiatric problems. Providers treating these patients should also entertain the possibility of organic sources of these problems. So rule out any kind of organic brain disease or other organic diseases prior to disclosing this as a PICS. So we should be very careful in describing this. So the spectrum includes the ICUAW weakness, the cognitive weakness. The ICUAW weakness is nothing but a muscle deconditioning, and this are encompassed by critical illness polyneuropathy, critical illness neuromyopathy, and critical illness myopathy, rather. There are several names, several types, which we are going to discuss. Most commonly encountered is ICU-acquired weakness, which is, what is that? That is a symmetrical weakness, muscle weakness in all the extremities, mostly, and those are checked by MRC score. I'm going to discuss it later on, as less than 48 on that MRC score scale. That is defined as a ICU acquired weakness. Most commonly, and 33% of all patients on ventilators, they come across this ICU acquired weakness. 50% of all patients admitted with sepsis, up to 50% of the patients who stay in the ICU for at least 1 week, they all experience this ICU acquired weakness. This may take more than this is so much so paralyzing that they take more than a year to recover fully. So it's a very big problem. In fact, it makes the activity of daily living difficult, including grooming oneself, dressing, feeding, bathing, walking, those are the activities of daily living. Those are become very difficult for them to practice. Now, regarding this different characteristics of critical illness, myopathy, critical illness, polyneuropathy, and critical illness, myoneuropathy. So how this myopathy are occurring? There are severe muscle atrophy affecting both type 1 and 2 fibers, preferential and significant loss of thick filament protein myosin, eventually sarcomere disorganization, electrical hypoexcitability of the muscle, and poor excitation contraction coupling. So those actually form the definitive characteristics of this kind of a myopathy. What are the electrophysiological features? We practice electrophysiological studies of this ICUAW weakness. If we do it, we can see that there are normal to minimally reduced nerve conduction velocity, reduced CMAP amplitude, reduced compound SNAP amplitude in critical illness polyneuropathy, and for myopathy, normally to minimally reduced nerve conduction velocity, reduced CMAP amplitude or the compound muscle action potential amplitude, reduced muscle excitability on direct stimulation, and increased CMAP duration, normal, maybe normal to minimally reduced sensory nerve action potential. Generally, sensories are not so much involved. So after looking at a patient, how do you diagnose ICU-acquired weakness? First and foremost, always is the clinical suspicion. You have to have a suspicion in your mind that this patient is having this kind of symmetrical muscle weakness. He may or may have a ICU-acquired weakness. If the patient is staying in ICU on ventilator or out of ventilator for a long term in ICU, you have to have this suspicion in your mind. And naturally, you are going to examine him in detail for his neurological examination. You can see the sensory and the muscle reflex examination, the muscle power examination, and the stimulation and the reflexes. Those you need to see accordingly. And now coming to the labs, you can see the muscle enzymes. You can do a CSF. You can do many things that, and later on neurophysiology that I'm going to tell later on. MRC scale or the Medical Research Council scale for muscle examination, there are so many categories. First, 0 is for no visible contraction, 1 is for visible muscle contraction but no limb movement, 2 is for active movement but not against gravity, 3 is for active movement against gravity, 4 is for active movement against gravity and resistance, and 5 is active movement against full resistance. So 4 limbs, maximum of 15 points per limb we need to see, and for 4 limbs it's 60 is the maximum score. And obviously, during evaluation, if we find it less than 48, we can term it as a ICU-acquired weakness. So, as per the examination, you can scale it like MRC. And obviously, you have to exclude all those pre-existing conditions where neuromuscular weakness were there already prior to hospital admission. Assessment of other premorbid status, consider conditions of acute spinal cord injury, MND, GBS, and muscle dystrophy. Those are all very much a deterrent for diagnosis of a ICU-acquired weakness. So these again, if the patient is having a viral illness, or he may eventually develop GBS. So you have to very carefully categorize those patients as those are not organic. If there is no organic reason, we have to clarify it as ICU-acquired weakness. Now, CSF studies you can see if there is a normal cell count and raised protein. So we have to see for whether the patient is having a GBS or not. Many a times we do not do it. We generally try to stamp it as a ICUAW weakness, but many a times, believe me, we have come across a lot of GBS syndrome and we have treated them later on and they have recovered fully. Direct muscle stimulation, muscle biopsy, nerve biopsy, these are all lab things. We generally, we do not go into that details in normal case, but if we require so, we have to go and do this. And electromyography is a must, and we have to see all those spontaneous fibrillation potentials, waves, duration, and all to define a critical illness polyneuropathy. So intensive care unit acquired weakness, you can see we have to see also the diaphragmatic weakness. Diaphragmatic weakness, how do we see it? We generally see by the muscle ultrasound on the bedside. I think many of us, we do it to see the muscle excursion, the diaphragmatic muscle excursion on the bedside by ultrasound. And diaphragmatic thickening, if it is less than 20%, again, it's a part of ICUAW weakness. And again, reduced amplitude of compound muscle action potential for critical illness polyneuropathy is a diagnostic, and compound muscle action potential and normal sensory nerve action potentials, that will show it, that will define as critical illness myopathy. And combined critical illness polyneuropathy and myopathy will be reduced amplitude of compound muscle action potential and sensory nerve action potential, SNAP and CMAP, both will be reduced in critical illness polyneuropathy and myopathy combined. Now, coming to the functional assessment, whenever a patient is being discharged, we should see it. We should see, and the functional assessment by FIM scoring. FIM scoring is, we do by these 7 levels. 7 levels by complete independence, like timely, safely, the patient is independently standing, patient is moving around. The 7 is the best functional independence score. And modified independence, again, by device with the support, the patient is standing. And then modified dependence is by under supervision, minimal assistance, moderate assistance. We can categorize those. And complete dependence is maximal assistance and total assistance. Those 2 and 1 are functionally completely dependent. So now, these things we have already told that with the ICU acquired weakness, you see, this actually increases our ICU length of stay. How? It increases the duration of the mechanical ventilation, it increases the weaning duration, it increases the hospital length of stay and ICU length of stay as well, and increased in-hospital mortality. So 45% within the hospital admission, and 20% more die in the first year of discharge. Those are by current opinion of critical care in 2005, these were declared. And morbidity is seen by 68% to complete functional recovery, but 28% they have a persistent severe disability. They do not come to good FIM scoring later on also. What are the risk factors? Risk factors have been very much well studied till now, and most of the studies have shown that the severe sepsis and septic shock singularly is a big risk factor. Multi-organ failure, prolonged mechanical ventilation, prolonged bed rest, and increased surge duration, increased duration of the multi-organ failure, hypo or hyperglycemia, both. Those are the major risk factors for ICUAW weakness. And possible risk factors are age, female gender, Then severity on admission, Apache score, hypoalbuminemia, and hyperosmolality, parenteral nutrition. The nutrition itself is a very big risk factor. RRT, the vasopressors, the steroids, NMBs. In another randomized controlled trial regarding the steroid, those have shown that steroids singularly is not a great risk factor for ICU-acquired weakness that we generally think. Aminoglycoside is another, and NMBs we all know about its great risk. So aminoglycoside is another thing that actually gives a major contribution. So how do we prevent from the patient going to the ICU acquired weakness? It's a very, very tedious job for all caregivers to take care about the patient's outcome. So the physician, the nurse, the family, friends, caregivers, nutritionists, recreational therapy, occupational therapy, the social worker, case manager, neuropsychology, all are actually involved in the patient care, and mostly the physical therapy, the physiotherapist. They are very much important contributor in preventing this ICU acquired weakness. So the ABCDE, you see the airway assessment, the breathing, the regular assessments of these coordination of care, communication between the various disciplines, delirium monitoring, these and early ambulation in the ICU. Those are going to tell you how you're going to make your ICU patients survivor ICU acquired weakness free. So you can see here the patient on ventilator is being made to walk with support, and there are so many people around helping her. So that actually improves the patient's own mental strength, and that boosts up the morale, I believe, and that is going to take care of the outcome. You can see there is a ergometric cycle. Ergometric cycle, these I have seen in major intensive care units in Europe. Mostly in the Brussels. I had been to University of Brussels intensive care. There I have seen this kind of ergometric cycles. They're using it to prevent the ICU acquired weakness. Now coming to the cognitive, the brain dysfunction, generally this encompasses the delirium, the dementia, remembering, paying attention, solving problems, organizing and working on complex tasks. These are very, very, in major patients, these are seen to be happening after a long term on mechanical ventilation or long term in ICU. The cognitive dysfunction may affect return to our work, balance a checkbook, or perform other tasks which involve concentration of the patient. There is a definitely short lack of concentration that actually enables the patient not to be cognitively very well. The assist with the use of mini mental state examination, we generally use it on the bedside, MMSE, and sometimes standard MMSE, that is much more easier to perform with lower scores indicating poorer performance. The contributory risk factors for cognitive decline is mostly the age, sex, ladies generally much more prone to have educational level, the socioeconomic status, addiction, mostly the addiction in this socioeconomic status is a big factor for this cognitive well-being. The physical activity level, the nutritional status, glycemic fluctuation, hypo or hyperglycemic variability, the previous neurological disorder, if the patient was having something prior to admission, long-term bedreddenness, pre-existing mental illness, pre-existing electrolyte disbalance, endocrine disorders, the level of suffering, mostly out of endocrine disorders, mostly the thyroid disorder is a major contributor in this. And level of suffering is also another big thing. And out of all, actually, what is appealing to me is the lack of communication with the patient. Lack of communication with the patient is a major thing that is not done in most of the places. Most of the places I have seen that the nurses and the caregivers, they look at the patients very mechanically. They do not consider the patient as a human being. So considering a patient as a complete human being is much, much, much important and required at this moment of time to prevent this cognitive decline. So coming to the evaluation of the cognition, there are several tools in our hand. One of those are mini-cog, then MMSE or standardized MMSE. It's better to use SMMSE plus the history taking. The history is a very, very important in this cognitive assessment. And there are other parameters also. The past medical history, the past surgical history, the social history, SNAP and the family history. These are all very much important. And last but not the least is the CAM ICU score that majority of us are now doing at the bedside in all ICUs. Now coming to the mini-cog, what we do is that 3-word registration. We tell 3 words and ask them to remember those 3 words, 3-word recall. So this is generally done by the patients on the bedside. 3-word recall 0 is a suspected dementia. 3-word recall 1 or 2 maybe suspected dementia or not. And 3-word recalls 3, no suspected dementia. So these are a very simple thing that can be done, 3-word registration. And then drawing a clock. You can see here, the patients have drawn the clock. This is a normal one. And you can see here a little disarranged numbers. There is a big gap here. And here you can see all the numbers are written one after another and the rest is blank. And here also you cannot find the clock hands. They're absent here. So this is another thing. And obviously these 2 patients are in severe dementia. So, and step 3 is this, I have already told you, the word recall, registration and recall. MMSE and SMMSE or standardized MMSE, you can see the mini mental state examination. There are, you can find it, whenever you search for it, you can find it. There are typical different scores. We can actually, it's a score of 5 whenever the patient can do it, or patient cannot answer this. What is the year? If the patient cannot answer it, you score it as 5. So score of 0 to 30 is the MMSE score, and 30, if the patient is scoring 30 to 20, 25 to 30, this may be normal. 21 to 24, mild or early dementia, and 10 to 21, it's a moderate, and 0 to 9 is a severe. They will not be able to perform the activities of daily living and communication, also speech disturbances they will undergo, and memory, all areas shows obvious deficits. And this how you score by MMSE. Now, regarding delirium. Delirium is an acute confusional state. This may be termed as a ICU psychosis or acute brain syndrome, altered mental status. These we generally come across again for the patient who is prolonged in ICU. So, or patient who are having toxic metabolic encephalopathy, sundowning, or delirium dementia. These are all different terms that we apply to delirium. And subtypes are generally hypoactive or hyperactive or mixed. That we can see the patients in hypoactive delirium, they are generally not very much abusive. They're cool and calm, and then, but they are not listening to you. They are not, answering to you. They're totally hypoactive on the bed. And hyperactive, you can imagine they're very much combative, agitated, and restless. So delirium and long-term cognitive impairment. ICU delirium is the independent risk factor for long-term cognitive impairment that we all generally know. And we have seen that also. And cognitive impairment is substantial, often persists more than 1 year after hospital discharge. So almost similar to the traumatic brain injury survivor. These are the facts that has come into picture once that brain ICU1 study has been done, that has come with these results, like 34% of cognitive function similar to traumatic brain injury survivor, 24% of cognitive function similar to a patient of Alzheimer's disease. And this cognitive decline is not just limited to the older adults. This is also happening into the pediatric patients, and substantial burden on patients. And naturally, these are eventually going to be a big burden for the patients' families. Now, coming to a confusion assessment method, or CAM-ICU, which we generally do on the bedside to assess the delirium, the state of the delirium, and to score the delirium status, is, you see, there are 4 major things that we take into account. Are acute change of fluctuating course of mental status. Is there any acute change from the mental status baseline, or it's a chronically the patient is like that? Has the patient's mental status fluctuated during last 24 hours? Patient was calm and quiet, and suddenly patient is talking all nonsense. So these are to be, evaluated. Inattention. Patient is not attending to whatever you say. If you are asking, or if you are giving some orders to the patient, patient is not following that verbal commands. And these are part of inattention, which we come across generally. Patient is not listening to you. So, and otherwise, the next step is the altered level of consciousness. You can assess that with a RASCL. And next is disorganized thinking. Like will a stone float on water, other fish in the sea? The patient's answer, if it is wrong answer, you can score it as a error. More than 1 error is CAM-ICU positive, delirium present, and CAM-ICU negative will be less than 1 error. So there is another scale that I'm not going to go into greater details, because CAM-ICU is a well-practiced scale on the bedside. So this is a intensive care delirium assessment scale. So ICDSC score greater than equal to 4 has a 99% sensitivity for a psychiatric diagnosis of or delirium. So now coming to the brain ICU study that had happened in 2012, and this was one of its kind, first done across the multi-center in USA. So bringing to light the risk factors and incidence of neurophysiological dysfunction or dementia in ICU survivors is the brain ICU study. So this brain ICU study, this was the brain ICU study 1, and another brain ICU study 2 that is going on this factor on cognitive impairment mostly. And this is now going on in USA. That is funded again by SCCM. The results of this brain ICU 1 study, they had enrolled 821 patients. 6% had already a cognitive impairment at the baseline, and delirium developed in 74%. It's so big a number. You see, it's a big amount of patients. Large amount of patients. They develop 74% almost. They develop this ICU delirium during the hospital stay. And at 3 months, 40% of the patient had global cognition score that was 1.5 standard deviation below the population means, and 26% had 2 standard deviation below the population means. So you see, it's the plethora of this problem is so much worldwide. There are several papers on cognitive trajectories after post-operative delirium, mostly taking into account all those cardiac bypass surgeries, and they had seen all those risk factors and the outcomes with these scorings. And even with the long COVID-19 is a fallout of a COVID-19 illness, which actually seen that many patients we have seen that they had deteriorated in cognitive function post their COVID illness. So they were infected with SARS-CoV-2, many of whom who had mild disease, they have reported this brain fogging or inattention, executive functioning, loss of executive functioning, language processing speed and memory. They have lost memory also. So these are the things, and together with increase in incidence of anxiety, depression, sleep disorder, fatigue, these are all part of this brain fogging that had happened with the long COVID-19 patients. These are all studied at large. Mental impairment, coming to the mental impairment in PICS, the depression, the anxiety, the post-traumatic stress disorder, nightmares, these are all part of this mental impairment. You can see there are so many things. Those are again, if the patient is weak, they are also mentally depressed. The fatigue, the difficult swallowing, these are all contributing to their major depression. Cloudy thinking, difficult concentrating, poor memory, these are also giving rise to the stress. Difficulty in sleep, this is also giving rise to the stress. Sadness, anxiety, these are all part of it. And you see, the patients, majority of patients, if in ICU, if you are going to talk with them, they can talk you in different, I mean, they see different types of nightmares, and they're going to tell you, like one had thought of sexual assault, some had a very painful experience they have, because they're mentally like that. They may not be that they're going to experience that, but it's a very painful, I mean, assault-like experience, mental experience. I'll say that is in their imagination. The ICU patient, imagine he had nightly to visit a sushi bar where he had to swim through a pool of man-eating fish. You see, there are so very, I mean, funny. It looks like very funny, but it occurs to the ICU patients. Some had flashbacks of hospital walls covered in blood. Many see some spiders there that are climbing their bed, and some patient had thought that he was on a conveyor belt. If the patient had actually undergone an MRI brain, so he thought that it's a conveyor belt that is putting him through a oven. And most common, you see, the many patients, they tell that the nurse is going to kill me. That nurse is going to kill me. That doctor is going to kill me. This is a very, very common experience by the patient. I mean, the talk with the patient, which we regularly see and regularly hear from the patient. So it turns out that even more upsetting than almost dying. So these are the types of delusions the patients generally have in ICU. The symptoms of post-traumatic stress disorder are flashbacks, recurring nightmares, overwhelming anxiety or panic attacks, avoiding thoughts of places reminiscent of a traumatic event, exaggerated stutter response. Recently, we had a patient in our ICU who had experienced a traumatic brain injury, and finally, she still tells us that do not show me all those pictures. I'm very much I'm afraid of those pictures. Do not show me all those pictures when I was in ICU. So she does not want to recall the stay in ICU. and exaggerated startle response, hypervigilance, anxiety, part of anxiety, it is recurring nightmares. These are all part of it. So what the PTSD as per the DSM-4 is exposure to a traumatic event in which the individual experiences, witnesses, or is confronted by actual or threatened death, serious injury, or threat to the physical integrity of self and others, or some close relatives, and responded with intense fear and helplessness or horror. That actually is PTSD, is what PTSD is all about. There are 3 symptom groups. One is intrusion. Because of the nightmares and flashbacks, the patient gets very much angry and having a very, intrusive symptoms. And the patient may have avoidance. Patient may have hyperarousal, not sleeping. Symptoms are experienced for more than 1 month. This is a very, very stressful thing for a patient who experience it for more than 1 month. If they cannot sleep for more than 1 month, it's very bad for their health. Clinically significant distress or impairment in social, occupational, and other areas of functioning. This also occurs in PTSD. There are different checklists with which we can generally come across or scale score, give some score like PTSD checklist 5 or PCL 5. We tell it regularly. So we can classify with different. 0 to 10 is none or minimal, 11 to 20 is mild, 21 to 40 is moderate, and 41 to 60 is severe. There are actually gradation in these, all those topics. Till 20, there are 20 topics on which we generally ask the patients which they're experiencing, and these are graded in 0 to 4. So according to, we score it. What are the diagnostic criteria for post-traumatic stress disorder is what we have seen in that PCL scale in last slide. 1 B item is question 1 to 5, 1 C item is 6 to 7, 2 D items question 8 to 14, 2 E items 15 to 20. A cutoff score is 38 for a provisional diagnosis of PTSD. This cutoff has high sensitivity and specificity. It has been seen by Cohen et al. In 2015. If the scale is used to track symptoms over a time, if minimum 10-point change represents a clinically significant change, which we should be taking acquaintance of. There are different studies on psychological recovery. You can see all those studies. I'm not going to tell in the greater detail. You can see all those. Now, how to care for PTSD? How do you care for a post-traumatic stress disorder patient? Mostly chemical. You can see SSRI are a big helper, and mirtazapine, venlafaxine, these are also can help us if there is a intolerance to SSRI. MAO inhibitor and adjunctive medications and other useful things are propranolol, clonidine, neuroleptics, these are all. And along with that, pharmacologic therapy, psychotherapy plays a big role in treating the PTSD disorder. So we should be taking care of that with along with the psychological evaluation, psychological counseling, as well as the psychiatric review. So coming to the next, the non-pharmacological measures that may help the PTSD patients: seek professional treatment and build an effective support system that includes people who can support you. Practice healthy coping strategies such as exercise. You can see there are physical activity of group of physical activity people. They're doing their daily yogas or exercises. And improved sleep. We need to consider the reversal therapy, mindfulness meditation, and yoga. These are very, very helpful for a post-traumatic stress disorder. Avoid using substances. Substance abuse have to be taken care of for this PTSD, because substance abuse actually can prolong this PTSD duration. Again, another study. This is a very, very big study that had happened and published in NEJM. That is the prevalence of post-intensive care syndrome amongst Japanese intensive care unit patients. Because you see, in Japan, most of the ICU recovered patients, they are with so much care and so much improved therapeutic strategies, they live more than 100 years. So this study was done in prospective multi-centered observation cohort study in 16 ICUs across 14 hospitals in Japan. The results were almost 25% died at 6 months, but amongst the survivor, the 96 patients responded to the questionnaires, and PICS impairment, more than one PICS impairment occurred in 63.5%, so big a number in 63.5% patients, and more than 2 occurred in 17 or 17.8% patients. So it's very, very important. That is why the advanced countries like Japan and USA, they are having their protocols in place to prevent this PICS. And this is a comorbidity index. We do not have to discuss all about this, Charlson. And prognosis of PICS, the long-term prognosis is highly variable. Varies as per the society, the economy, the race, and to some extent the correction methods and all. So these are variable. The study by Mara et al., they had studied it for US 406 US survivors and found that the rate of physical impairment improved from 23% to 17% between 3 and 12 months post-discharge after practicing all anti-PICS measures. And cognitive deficits have reported in 25% of ARDS and sepsis survivors. 6 years, even 6 years, you see, the cognitive deficits actually persist. They are prolonged. They persist long time beyond ICU discharge. What are the fallouts? These are the physical impairments, psychosocial, fatigue, pain. These are generally not discussed so much, but they are really they are troublemakers for the patients, ICU survivors. You can see the fatigue occurring almost in 24 in elective surgery, and medical 36 and 45 in urgent surgery. These are all big numbers. And depression syndrome, you can see all those, frailty, PTSD, these are all part of it, but mostly the fatigue is a big thing that is very, very important in this post-ICU patients, ICU survivors. And ALTO's study, this was a newer study that happened almost, they had actually taken out, this is secondary meta-analysis of the ARDS net protocol, the ALTO study, the long-term outcome of ARDS patients. 50% of ARDS survivors reported clinically significant pain during the first year after ARDS. So pain is another thing that occurs in the as a post-ICU care, part of the post-ICU care syndrome. And what is bugging us is the delayed return to functionality or work. That is actually a very, very big problem. That most of the developed countries are seeing now. Approximately 36%, 64% or 60% of patients reported return to work at 1, 3, and 6 and 12 months following up, respectively. So how do you prevent this? This assessment of airway, breathing, coordination, early intervention and rehabilitation, the delirium assessment, nutritional assessment and nutritional therapy, both environmental management for healing, nursing care for PICS, the ICU diaries. It's very, very important. ICU diaries are now going to be, the concept is going to be spread across the US. There are now ICUdiaries.org has been a website. Those are promoting this ICU diaries. ICU follow-up clinics, This is a must for a country like India, and the safe and good end of life care practice, those are going to affect or prevent the PICS. Early ICU psychological intervention is a must. Clinical psychologists have to take care, provide emotional support, and they should educate the patients, the stress management protocols, coping strategies, and trauma patients. They have to be there. They should be available 24 hours. They are not available 24 hours, but yes, they have to be. Observation study of those with and without a clinical psychologist, that those are to be in place. Trend towards the less depression and anxiety has to be there in the society, and statistically significant decrease in PTSD with all those measures are seen already. 21.1% versus 57%, you see. Wherever they have implemented, they have those improvements. This ICU diaries, there is ICUdiary.org that is taking care of this ICU diaries. They have said that after initiating this ICU diary, the PICS eventually had come down to a great extent in US, that they have told, but we need to see further. This is a post ICU care this clinic, which we need to have in every hospital, which we generally do not have across India, but we have to have this. So critical illness is a family crisis. So encompassing the care to and extending the care to the family has to be there. If we tend to, retain this PTSD, tend to reduce this PTSD occurrence and depression amongst the patient's family, feeling worried and confused can cause family members to stop tending to their own health. Generally, what we tell to the family members is that please take care of your own, daily this thing, the nutrition and all. You have to take care, because we are taking care of the patient. You just take care of yourself. That we generally tell during counselings. The care team may ask the family to make decisions about important, sometimes overwhelming matters like patients, not for resuscitation and all. So there are different overwhelming matters. They need to take a major and distressing decisions. Because of this, 30% of the family members may experience their own mental health problems. So these are to be taken care by us itself. So what the family needs is that to have a hope and reassurance and receive information. This hope should not be a false hope. It should be a positive. It's a true hope. And receive information, to have comfort, to have support, to be near the patient most of the time, to receive the timely information about the patient. Now these are being practiced. Earlier it used to be not there, but now it is regularly practiced. The thorough counseling of the patient's family, to talk with the doctor each day, to be with the patient, to have hope, and to be assured the patient is receiving the best care and the right treatment in the right direction. So we have to ensure the patient's family are comforted and rightly informed. So these are again the same things. The family members may need a psychological support at times, so the psychologist or the psychiatrist have to support them. And many hospitals actually offer social workers. I have seen those in major hospital in Delhi, like in Gangaram Hospital. There were a social worker associated with our critical care team, and case managers and chaplains to support the family and their families through their critical illness. Many times the patients who are brain dead, they need to take a decision on organ donation. The social workers do a lot of support in that scenario. This is a small, poster by Chest. I found it very useful, so that I had posted it here. So critical care recovery programs, clinics, you can see this is given prime importance to this chart. And PICS in the caregivers also. We need to see family and the loved ones. They have to be devoid of PTSD. And finally is extending or continuity of care towards the home is a big thing for ICU at home right now. The patient will becomes a little more happy than whenever he is in the hospital. They have a faster recovery. That is our experience that I have had with my patients. The patients really, I mean, recover so fast whenever they go to a home care facility, and literally good care. If it can be arranged at home, it's very, very great for the patient. So these are my resources. These are my two sweet patients who are very happy after the ICU. Now, please, questions and all.
So I think that was the last slide, ma'am. Please stop the share screen.
This one, or
No, if you have finished, right?
yeah,
Yeah, so just stop the share screen.
okay.
So
Yes.
if you have any questions, please put up your questions. So, Dr. Leelavati, ma'am, you said about ICU diaries. What exactly did you mean by that? Something new has come up in ICU diaries?
Yes, this ICU diaries it's a method of coping with a post-traumatic stress disorder, because patient, they I mean, they are in most of the time they are in delusions that they are being attacked by the nurses or the doctors, or actually they mean whenever the blood samples are taken and all, that becomes a very painful experience for them, and they actually have a psychosomatization that the nurse is going to attack him or her. And they, whenever the patient's relative come to meet their patient, they tell it across the patient's relatives that I had been hit by this nurse, I had been hit by the doctor, I had been abused by this patient caregivers. So these things will actually go off whenever the patient ICU diary is in place, because they can be shared by the patient's family. At the same time, the caregivers, they can put their event note and the photos of the patients, and more communication between the patient's family, patient and the patient caregivers. Three of them are actually improved by ICU diaries. That they are telling. I didn't practice it yet. I have recently come across during studying all this.
Yeah,
So I think I may implement this.
I don't think it is being implemented yet in our ICUs, as far as I know, because even I was not aware of this concept, something new. So I will just like to reiterate some points from what ma'am has said. So if you ask the patients what is the strongest recall from the ICU, they say it is pain. Like she mentioned, pain is an important factor.
Exactly. Yeah.
So we should give adequate energies here. And what exactly is PICS? PICS has three components. Post-intensive care syndrome has three components. One is cognitive dysfunction. Second is psychiatric dysfunction, and third is mental physical health issues. So the cognitive dysfunction actually, in terms of impaired memory, impaired concentration, impaired carrying out mental tasks, or psychiatric issues like flashbacks, post-traumatic stress disorder, these are strongly related to delirium. If patients develop delirium, they are very likely to have these issues. And the strongest factor linked to delirium is the use of sedation. If you use too much sedation, then it causes problem. That is the reason actually why midazolam was stopped. You know, earlier, 5-6 years back, we used to use a lot of midazolam. But then this study showed that midazolam compared to propofol and dexmedetomidine is causing a lot of post-intensive care syndrome. And in fact, much before that, patients were deeply sedated. They should be deeply sedated because it was thought that if you keep the patient deeply sedated, the patient will be more comfortable. However, studies later showed that these patients who were deeply sedated were having a lot of post-ICU neuropsychological symptoms. So this was why we have to keep the patient lightly sedated, not deeply sedated, avoid midazolam, and take care of the usual bundles to prevent post-intensive care syndrome in terms of neuropsychological issues. Coming to the physical health, so in physical health, there are two key issues. One is ICU-acquired weakness, like ma'am had showed, and the usual care bundles, the usual things have to be done to prevent ICU-acquired weakness. And the other thing is the respiratory dysfunction. So it has been seen patients of ARDS have significant impairment, sometimes to the lasting up to even 5 years in terms of the restrictive dysfunction and obstructive dysfunction. And 1 year impairment in lung function up to 1 year is very common in ARDS. So one should be aware of all this and try to prevent. We cannot do the core treatment of the actual disease will remain the same, but the ICU care, the overall ICU care has to be much better in terms of meeting out the treatment, and this prevents the majority of symptoms in post-intensive care syndrome. And so, and also, there's a lot of stress being put on involving the family. Involvement of the family in terms of letting him meet the patient every day, talk to the patient every day is therapeutic both for the patient and the family. And in fact, there was a study in which patient's family was allowed at the bedside during CPR. And the outcome from and the feedback from the family was positive, that they actually were more appreciative of this being allowed at the bedside during CPR. So there's a lot of stress on this, involving the family with patient care, allowing the family to sit by the bedside. Though this can be difficult at times, but this helps the family and the patient in terms of neuropsychological issues. So those are the few things I wanted to add. Rest, if there are any questions, I don't think there are any questions. So I think Dr. Leelavati ma'am, should we conclude before you want to say anything?
Yes. You see, in the very last slide, I had shown two of the patients. The first, the female patient, she had undergone 3 CPRs back to back, one in another hospital outside and 2 in our hospital. So after that also, she has come out very well, because we communicated with her even when she was on ventilator. She had a bad ARDS drowning case. She had a bad ARDS, but she recovered very fully, actually, and without any post-traumatic stress. So I think we could be able to prevent the PICS in that patient. So that is why I had taken that picture and put it into.
Actually, the treatment of PICS is to prevent it, to put the care bundles properly, the
yes,
supportive
exactly.
care. Because the actual disease has the same treatment, you can't do much about it. But the supporting treatment, the surrounding treatment has to be appropriate.
Exactly.
To prevent PICS. It is a prevention. Okay,
This
we'll close it then. Thank you so much.
Yes, thank you very much, Dr. Tapesh and others who have logged in.
So we thank the audience for their patient hearing, and it will be up on our YouTube to review it. Thank you so much, Dr. Leelavati. And thank you.
Thank you.